She hasn't had a shower yet. I'll tell her.
I'm not on Facebook anymore since I started school.
Can you wait till break? Because I need to get started so that you can listen. All right, let's get going here. We're talking about the aging process this morning. We will look first just briefly at middle-aged adult, which unfortunately that is where I am. I am considered a middle-aged adult. It's Module I. All of it's not going to exactly be directly from your book. Who asked me that? But it's in, if you look in the front part, I don't remember the chapter number right offhand. It's growth and development. Growth and development. Okay, page 571. Look at the middle-aged adult. These are years between 40 and 65. We typically have grown children and elderly parents during this age group. It's called the sandwich generation because a lot of times, you not only have you as the adult living in the house, but you also may have your child living there as well as a parent, that you're trying to take care of. So you're kind of sandwiched in between the two generations. During this time, we're looking at personal and career achievements. They've often been met by this time. Now, as we all know, there's a lot of times they haven't because of situations that may have occurred when we were younger and didn't get to go into school like we needed to at the time or would have liked to. And so, therefore, we end up pursuing different interests at about this age. Sometimes it may be just a total change in career, because you may have had one career and decided that you wanted to do something different. And so, therefore, that's when we see folks coming back into school. Most often, and again, we're looking at, in general, the socioeconomic stability. Most people between the age of 40 and 65 are fairly stable. There's not a lot of fluctuation in income. We're pretty stable as far as a job in most situations. It's the time to start preparing for retirement, which I have to say I picked up one of my AEA journals this morning that had just come yesterday, and I didn't look at it yesterday. And as educators, we're about to get a 2.5% pay cut. Yeah. Fun stuff. We haven't gotten a raise in
3 years.
Longer than that. Quite a long. They don't look, the legislature doesn't look at it as a pay cut. They look at it as what they're doing is mandatory, our retirement system, is they are taking a 2.5% increase out of our check to go into the retirement system. But at the same time, the state is reducing their funding into the retirement system by 2.5%. So they're basically balancing the budget off of the backs of the educators. Mm-hmm. So it, in their eyes, they're not taking a pay cut. They're putting it into your retirement, and it's going to be there for you later. No. We haven't had a raise since right after Riley took office.
That's the only time you'll get a raise.
New governor this time's not giving us a raise.
North Carolina is different. When it's a whole, when you got laid off and a whole lot of people start going back to school, That's when they start getting raises every so often.
Not in Alabama. We haven't gotten a raise in, I believe it might have been right, like his second or third year in office, maybe, and he was there for 8 years. I mean, it's been a long time. I've been back 5 years and we haven't had because I left and went and did something else and came back. And during the whole 5 years I've been back, we haven't had a raise. I get a step raise this year. Yeah, we go in steps, like until you get to the 10-year mark, you get a step raise every year. After you get to 10 years, then it's 5 years before you get another raise. And on so forth. So I do get my step raise this year, but obviously it's going to go back into my retirement. So, but that's just the way the state has done.
More like cut their pay, like the government and the teachers. It's more like cut them in half, and then the teachers and.
No, they just keep getting raises here.
No, they get raises. Teachers get raises, but they cut everything for government. Those people, they don't get work. They don't care.
Well, that's not the way it happens here, but we won't dwell on it. We'll go on. But, you are preparing for retirement, and in most companies, it's your choice as to how much you're putting into your retirement. But in a state job, we don't have the choice. They simply take it out and put it into our retirement, which will hopefully be nice when I get to that point, but it'll be a while yet. Physical changes that occur during middle adulthood, you have to begin to accept those changes that are occurring. Unfortunately, there's not a whole lot we can do about it. Many of the physical changes may not occur until later in the developmental period. However, at about age 40, we do start seeing some changes begin to occur. With the integument system, if you look in your book, there is a table, and that's table 19.2 in the old book. But you will see that we begin to have different changes in different body systems. Everything starts to slow down as we get older. The integument, you begin to see some drying of the skin. You might begin to see some dark spots begin to arise, but with the eyes particularly, you start to have diminished eyesight. I've already noticed, and I've just noticed it over the last 3 to 4 months. If I hold, like videoing with my video camera, and I'm trying to look at the screen, it blurs. So I'm beginning to lose that up-close vision, where I've not had, until the last few months, had a problem with vision. My vision has always been 20/20, but it's beginning to change. With our hearing, we start having some changes there as well. It begins to diminish a little bit, not drastically in the 40s, but you will see that with each system that you have specific things that begin to take place as a way of preparing your body for old age, is essentially what it's doing. During this 40 to 65, most as females begin to go through menopause during this age period, you start seeing vaginal dryness. Some people even begin to have pain, particularly in the latter part of the developmental period. Even males go through a male menopause where the hormones begin to decrease. not as drastic as females do, but you still have some changes there. Musculoskeletal, you start having some, a little bit of atrophy of muscles, changes in strength a little bit, but pain is not one of the normal aging changes. And so you need to understand that. A lot of people think that arthritis is a normal aging process. It's not. Arthritis is a disease process. It is not a part of normal aging. So pain to the joints, pain to the muscles, that is not normal. Okay? So you need to be aware of that. Neurological changes, you really don't see a drastic change neurologically until later. And really, there's a normal aging process. You should not really see significant changes except maybe in some short-term memory. And that's a normal aging process. Your long-term memory should stay intact. Most of your short-term memory should be intact, but you will see patients, begin to not be able to remember what happened 30 minutes ago or yesterday. I already have that. I can't remember what I did yesterday a lot of days. But also a lot of times that's more stress-related, because of so much, you're doing so much and you just can't remember, what you did at what specific time. So
that can be stress-related?
It can be. Cognitive development changes are few, as I already mentioned here, except during illness and during trauma. We tend, as we get older, we adapt more slowly to new or unusual problems, but we still maintain that ability to problem solve. We don't lose that ability during the midlife. Erickson's developmental stages. Have y'all covered growth and development in assessment already? Not yet. Okay. Well, when you get to talk about growth and development, you'll talk about it across the lifespan, from infants to elderly. But during the midlife, that 40 to 65, we're in Erickson's developmental stage of generativity versus stagnation. Now, basically what this means, Erickson starts out with trust versus mistrust. You have to gain that, as an infant, you gain the trust that you're going to be fed when you are hungry, that you're going to be changed when your diaper is wet. You develop that during infancy. He has several stages that you go through as you get older. And this just happens to be the one for the 40 to 65 age group. This is the central task that you're trying to accomplish, is generativity versus stagnation. If you accomplish generativity, then you're going to have positive outcomes. Okay, generativity, you're looking toward the future for your children, for your grandchildren. You're trying to teach them things that they need to learn in order to be a better adult, to have a career. You are helping them with their future. Okay? With your grandchildren, you may be helping teach them how to ride a bike or how to swim, or different things that they may need to know as they grow up. You're working. You are getting ready, preparing with your job. You're preparing for retirement. If you are stagnant or in stagnation, you have a negative resolution. Generativity is positive. Stagnation is negative. You look back at your life with bitterness, with, I wish I had done this, I wish I had done that. With generativity, you're looking at your accomplishments, and talking positive about what you've done, where you've been. But with stagnation, you're looking back at the things that you didn't accomplish that you wished you had. Does that make sense? You're looking more at the negative side. Yes, shoulda, coulda, woulda. That's a good way to look at it. But that stagnation, those are the people that end up a lot of times in depressions, because they are dwelling on what they could have done but didn't. All the negative issues in their life, they're dwelling on those, and so they become very stagnant. And of course, what do we want all of our patients to do? We want them all to accomplish generativity, but they won't all accomplish that. And with Erickson, he says that you have to accomplish a stage before you can move on to the next stage. So, if you're in generativity versus stagnation, you've got to accomplish generativity before you can move on to integrity versus despair, to that stage of development, which is your 65 and older age group. Okay? A lot of times in the hospital, you will find that there are some patients that never get out of the trust versus mistrust. And you will see their problems that they have all along the way with development, with their life, because they were never able to accomplish trusting someone, being able to put trust and faith in another person. According to Erickson, the primary developmental task is to achieve that generativity, which is basically what I just said. Expected events is children moving away from home that may occur during this. If you, as a parent, end up in that empty nest syndrome and can't get out of it, then you may not accomplish generativity. Okay? But if you are positive and go forth with your life, even though your children have gone on to college or maybe have married, then you will accomplish generativity. Career change by choice or not can be a stressor during this stage of development. I mean, even though you may want to change your career, which we see a lot of people do, it's still going to cause there to be a lot of stress in the life. Okay? Even though it may be something you want to do, it's still a big stress. And some of you can already tell me that. Something you want to do, but it's still a stressor. If it's something that occurs like you got laid off or you got fired from a job, then naturally we automatically know that's going to be a stressor. But we don't always think about the choice that you make to move on to something else as being a stressor. I can tell you that a few years ago when I left and went on I was unit manager on an Alzheimer's unit, I made the choice to leave. But I can tell you how much of a stressor it was. I started losing hair. I started getting sick a lot. Just a whole lot of things began to happen because it was such a stressor on me. So, of course, you know the end of that story. What did I do? I came back.
Well, Miss Brown, I kind of did the difference about getting laid off. Because my dad got laid off 2 years ago, and he just was happy as I don't know what. I mean, it's different.
Everybody's an individual. Everybody's an individual, so you also have to take that into consideration. Middle age, health promotion things that you need to be aware of is middle-aged adults are more prone to stress-related illnesses, such as heart attacks, hypertension, migraines, backaches, arthritis, cancer, and autoimmune diseases. I can vouch for that myself. I was diagnosed a little over a year ago with spondyloarthritis, which is essentially a it's not quite rheumatic, rheumatoid arthritis, because they don't have the RH factor. But the pain that goes along with it is very much similar to rheumatoid, and it is more or less an autoimmune disease. Leading cause of death during this time is heart disease, cancer, stroke, accidental injuries. And with accidental injuries, why do you think that would be a leading cause of death with a middle-aged adult? Okay. The changes in your reflexes, your changes in your sensory system. But also, what are we trying to do? You're still trying to be young. We know we're growing up. But what happens during middle age a lot of times, they'll hit middle age crisis. What do you particularly see with males that hit middle age crisis?
They go by a motorcycle.
They go buy a motorcycle. They go buy a sports car. My husband bought both. And sometimes they go try to find a younger woman. That is true. But I can say, my husband did. He bought a motorcycle. He bought a Miata. Realized after he had back surgery with the Miata that he couldn't get in and out of the car as well, so we had to get rid of it. Prior to the back surgery, the motorcycle is what showed him he had to have it because he was getting numb. He rode the motorcycle from here to Lineville and back. He had to stop 3 or 4 times along the way because his arms got so numb. So we now no longer have that. We sold it to Mr. Howell, and Mr. Howell wrecked it. Deer ran out in front of it. We did. After the motorcycle. So it happens. Those are things that occur. Well, the motorcycles, the fast cars, things like that lead to more accidental injuries. Things that you need to teach your patients to promote their overall well-being, and we'll look at mammograms on the next slide. But testicular self-exams, we need to teach patients that are 15 years and older to do testicular exams once a month. We also need to do self-breast exams once a month. You will find in assessment also that when should you do a breast exam? What time of the month? After your period. I didn't know they had changed that. The books hadn't changed yet, so I don't think.
What if you don't have a period anymore?
You pick a month, pick a day of the month. As long as you don't still have your ovaries. If your ovaries are still functional, then you would need to wait. You typically ovulate about 2 weeks before your actual menstrual cycle, so you would need to wait about 3 weeks after you ovulate.
What about if you have a birth control that makes you pregnant?
Then you could pick a day. Yeah, just pick a day. And do it that same day every month. Okay? Alright, rectal exams and colonoscopies. These are typically done yearly after the age of 50, unless you have a history of colon cancer. If you have a history, then they're going to start them earlier. Same thing with breast cancer. If you have a family history of breast cancer, then they're going to want to start mammograms much sooner. Okay? Calcium, there is controversy now. I've been hearing bits and pieces of it. Hadn't heard what they finally decided was the appropriate amount to be taken every day. But there's been some controversy over how much calcium and how much vitamin D that we should take as supplements. on a daily basis in the news over the last few months. But right now, it's still men over 50, they need about 1,200 milligrams per day, and women need 1,200 to 1,500. And of course, we have to have the vitamin D in order to absorb the calcium. So if you're not getting your vitamin D out in the sunlight, which is where the natural vitamin D comes from, then you need to be taking supplements. But you need to be aware of what could be a toxic level, so you need to make sure that you talk with your doctor before going on these supplements. Weight control is also something we need to teach, because you saw one of the leading causes of death during this time is heart attacks, so we want to reduce the cholesterol levels. So they will probably need to be on a low-fat diet, but they do need to be aware to minimize fat intake at least and control their weight. The focus needs to be on the goals of a positive health behaviors rather than on things that it's not healthy for them. Females, breast exam. If you're 20 or older, you need to do a breast exam monthly, as we just mentioned. 20 to 40 need a breast exam by a healthcare provider a minimum of every 3 years. Women 40 years or older need a breast exam annually by the healthcare provider. Mammograms, the asymptomatic is age 40, is what the current guidelines in the books are. Women age 40 or older need annual mammograms to make sure we're not having any problems. However, if you are symptomatic prior to age 40, if you find a lump, then you will probably be put on annual at that point. Okay? But it's very important that anything that you identify that is different, and you've got to know, as females, for your breast tissue, you've got to know what your normal is. So you've got to do those breast exams in order to know what your normal is, so that if something arises, then you will find it. Males, you also have to know what your normal testicular tissue feels like, so that you identify when there is a problem. Any questions on the middle-aged adult? After the age of 50, they were to be like every year. Now again, they may have changed it, and it just hadn't got in the books yet.
I think if you have a history when they found something, when they found polyps, you have to do that.
Mm-hmm.
After this, then you do the history, and then you count 35 years.
If you've had polyps.
Yeah. And on the woman,
Yeah. Because they've got to keep a check on it. If they found something, they do need to keep a check on it more frequently.
Yeah, on the woman, the mammogram, after when you go on 40 and every 3 years, after you 50, every 3 years, if you don't have any family history and if you don't have anything,
They just changed it.
Yeah.
Okay. I haven't seen that. I have seen, where they were talking about some changes, but I haven't seen the specifics on the changes.
I mean, my doctor told me that. I know.
Okay. Well, I go in July, so he'll probably tell me that too. Of course, mine's going to fuss on me because I haven't been in 3 years anyway. So, I know, I'm bad. I can tell you all day what you're supposed to do, but to do it myself is a whole different ball game. Yes, you are exactly correct.
Yeah.
We can take care of everybody else but ourselves.
Not to change the subject, I use Dr. Oz. He's on the Time magazine, and he tells you to eat the right food and everything, and I don't expect him to be sick. But he had cancer, and when he went for an x-ray, they told him nothing by mouth. Of course, he cheated. He ate before he went for his x-ray. So.
Now, that was wrong in him to do that.
He admitted. He knew better than that.
Yes, he knew better.
Now he would have died. It would have been a whole nother ball game.
Mm-hmm.
I thought he put the sleeve for that.
For x-rays?
I thought he got a colonoscopy.
Oh.
He showed it on TV.
It's your conscious sedation is what's used for colonoscopy. So you're drowsy, but you can follow directions, do what they tell you to do. So it is called conscious sedation. Okay, your older adults. The elderly has been called the fastest growing minority over the last few years. Because of our advances in healthcare, advances in technologies, we are able to live longer than what our ancestors were. You know, years ago, if you made it to 50, you were doing good, you know, long years ago. But now, we're much older. The aging process does begin with birth, and it continues through the lifespan. We have changes throughout. The care of the older adult presents challenges to nurses that require skilled assessment and creative adaptation of nursing interventions. So we have to adapt to them. They don't adapt to us. Okay, we have to make changes in care to help them rather than them make changes to help us. So it is something that you see in the nursing home a lot. And you will see that, you know, a long time ago, and one of the former administrators of the nursing home where I work, it's actually the owner's son. He now owns Arbor Springs in Opelika. I could hear in the back of my head what he always told my nursing students, because he would always, when I'd take them to the clinical, the last day, he would want to talk to you and tell you, you know, what they had to offer as far as career choices and things like that. But he would also tell you that when he was a young boy and watching, you know, his father and them with the nursing home and everything and coming to visit and different things, that back then your elderly was that you saw them sitting out on the porch, you know, rocking in the rocking chairs, talking. They could do for themselves. They could get up and move around, go about their business. That's not what we see in the nursing homes today. Those people that we used to see in the nursing homes are still out driving on the road. You know, going where they want to go, doing what they want to do. What we see more in the nursing homes today are those elderly that have disease processes going on that need medical attention rather than be at home by themselves. They can't give their medicines to themselves. They don't know their medications. They have so many disease processes that are causing problems for their body that they just simply can't take care of themselves anymore. Because of the complex disease processes that they have, it requires very good nursing skill to be able to assess these patients and to pick up on those changes. In the nursing home, you are truly the eyes and ears for that doctor. Okay, you're the only one that sees them. That doctor may come once every month or once every 2 months. You know, they're only required to come about once a month. I think they have to do an assessment, make rounds on them every 30 days. Okay? So you are truly that doctor's eyes and ears. So you have to be able to have good assessment skills in order to pick up on changes that might occur that the doctor needs to be made aware of so that he can make changes in their care. Okay? So it's not like it used to be. You know, used to they had kitchen where they could cook in, and different things that they could do. All the safety regulations and everything now, we can't allow that without extreme supervision. That used to be one of our activities. We had a couple of little ladies that would go down and make biscuits. That was one of their activities. Of course, they were under strict supervision doing that. But they could still, have that ability. So, geriatrics, the definition here is the branch of medicine concerning the care of the elderly. When you talk to nurses that work in nursing homes, they'll tell you they're geriatric nurses because they care for the elderly. But we do have to make a lot of changes and adaptations to these patients because they can't always do the way we need them to do or want them to do, so we have to make changes to accomplish the same goal. The definition, gerontology, a holistic study of the aging process. Gerontologists are those people that study aging. Gerontological nursing is the field of nursing that specializes in the care of elderly. Who are the elderly? This percentage has probably increased a little bit over the last couple of years, but approximately 12 to 15% of our current population now is over the age of 65. We are needing more and more nursing homes for patients. Now, right now, in our facility, we have several empty beds, which is highly unusual. We normally stay completely full, but we've had several residents over the last few months have passed away, and so we have several empty beds that haven't been filled. But most of your nursing homes are going to have a waiting list to be able to get in. And the way the state has changed the rules and regs on nursing homes with the new MDS, which is the minimum data set, which is the information that's submitted on each resident to the state every 3 months. The way they've changed the regulations on it, you now have to try within, and I don't know all the specific guidelines, but within a certain amount of time, thorough documentation has to be done as to why that patient can't go back home. I mean, to the point where you have to contact the health department, and the health department searches for placement within the community. Yeah, so a lot of changes have been made, which also may be affecting why we still have so many empty beds. It's because there's much more stringent criteria to meet to be placed in a nursing home than what it once was.
Why are they making it harder? Because we're busy had so many people that's going that we have the ones that can't get in there?
It's your Medicare and Medicaid agencies. Cost. It's a whole lot cheaper to keep them at home than it is to put them in a nursing home.
So we're talking about only the Medicare and Medicaid people, but if you're private, you don't have to be on the waiting as long as they have, right?
No, well, it depends. It depends on, you still have to meet the criteria to be admitted to the nursing home. But as far as payment options, it might be a little bit easier for a private pay to get in. But you still have to meet certain criteria.
So you have to have a chronic illness to qualify?
Pretty much. I don't know all the specific guidelines, but pretty much that's gotten where we're at.
So you're saying that you just older person, and let's say, because in some cases, some people, all the children are there, and you don't have anybody take care of you, and you're starting to just slow down to the point where you just can't do much. So you could just, and you didn't have a chronic illness, but
it would be, that could be a potential that you wouldn't qualify. It could be. Because documentation has to be done on their cognitive ability. It has to be done on their medications and how many, are they able to recognize their own medications and things like that and be able to safely administer their own medicines. So it's more than just that chronic illness. But, of course, if you're looking at medicines, you automatically know they have a chronic illness. But, yeah, there's a lot of criteria that has to be met before that person can come in now. Probably. Mm-hmm.
Yeah, in Alabama. I don't really know, but I know in Georgia, in order to get, with the parents, well, my friend now is going through it, putting her mother into the nursing home. Now the nursing home went to the point where they're taking the estate. So now children don't want to put their parents and stuff in the nursing home because they lose all their estate and homes and stuff because once that person goes in,
it goes, right. That is correct. It has to, their land and monies and things, checking accounts needs to be in the child's name for, now they have upped it to, I believe, 7 years. It was 5, and I think they were going to up it to 7. But I'm not 100% sure. But they've upped it from 2 years, because it used to be it had to be in there 2 years, and they've steadily increased that amount of time. So
they get all the elder's possessions. Do they use that money once it's paid?
yes.
But they do give them some money. I think it was like $30 or something.
They get $30 out of their check a month.
Yeah,
Is all they get. They are only allowed to have, I believe it's $3,000 in a checking account. We've been through this with my mother-in-law
Or, $3,000 in a checking account.
at any given time.
I've seen it though where like they have to go buy all new clothes and things like that because they've got too much money.
Yes, we had to do that with my mother-in-law. We had to make sure that it was spent, so that...
But prior to going to nursing homes, if they have money in their account, that money is spent before Medicaid or Medicare kicks in.
there is a certain amount of time that you have to spend it.
I mean, it pays for their stay.
And it has to be spent on that patient. Yeah. It's crazy, but... Yep. This age group has grown twice as fast as the rest of the population, again, because we're getting better care. By 2030, it's estimated that 20% of the population will be over 65 due to the fact that the baby boomers that were born between 46 and 64 will be that part of the population by 2030. You're a baby boomer.
Never considered myself.
Care of the elderly represents challenges to nurses that, as I've already mentioned, require the skilled assessment and creative adaptations for nursing interventions. And culture often defines who is old and sets roles and expectations of old age. And that's our culture within the United States. We have defined who is old. Now you have categories of the old, the young old. Senior citizen used to start at, 55? Now they've upped it to 65? I knew it was in the 60s. So, but here's the 55 to 75 is labeled as the young old. 55 to 75. And then 75 and older is the old. Your frail elderly are those adults who have a lot of physical health issues and declining resources, and they become the most vulnerable within the elderly population. It's not directly related to age per se, but it is a risk factor. We also see that risk factors of disability and those multiple chronic illnesses also play a part in a person becoming a frail elderly person. 75 and older, or that old age group, is what the age group that's at most risk. We see that with aging we have specific problems that can occur. They get a disproportionate amount of income, and it is usually very low income. My mother's 86 years old, and I don't know exactly how much she gets per month, but it is less than $1,000 per month that she gets to live on. And she worked for 40-something years. And it doesn't qualify for a whole lot.
We don't have this on our outline. Are there any key things that we need to know from that?
Well, yeah, there is. I mean, each one of the bullets there, you're going to need to know this and this as well, but it's going to be on Camtasia. So anything I say is going to be on Camtasia. But with that low income, my brother talked my mother into applying for food stamps, just because, he felt like she deserved it. And it took my mother a long time to be able to make herself go fill it out, because, it's a pride issue. And do you know how much she got?
She probably got like $20. And that's a shame.
$11. So it's, it's sad for our elderly because they don't have the income. They have to a lot of times make the choice between buying their medicine and buying food, which is very difficult for them to do because a lot of them need their medicine. Luckily, my mom, she's not on a lot of medicine. She's only on maybe 3 things. She's on some calcitonin for osteoporosis, and she's on a little heart medicine, and she has a chronic lung problem, so she takes antibiotics every weekend to prevent infection. And so her medicine, is not that bad because of the plan she's on with, through Medicare and everything. Maybe $2.50 for her medicine, which is a good thing. There are some that don't have that. Mom happened to be in that low income bracket and was able to get, the medications like she did. But she still thinks, like the other day, I went and bought her medicine. I mean, it wasn't but $2.50. My gosh. Do you know what she did? She wanted to pay me back that $2.50. And I wouldn't take it. So, you know what else she did? Mm-mm.
She went and bought you something.
She gave it to my kids. Gave it to my kids. She lives alone. She's 86, but does everything for herself.
My stepdaughter's nanny is 94 years old, and she still lives at home, and she still does pretty good for herself.
Mom does. She does real well.
With that generation, though, like a lot of the older women, they never really worked, and their husbands was like either in the army or anything like that. And like my grandparents, for instance, if something happened to my granddaddy, if he hadn't saved what he had saved over the years, My grandma probably couldn't make it because she don't draw much because she didn't work hardly.
Well, my mom worked, and she still don't draw nothing. I mean, Mama worked in the cotton mill. Hard labor, and essentially doesn't get anything. So.
Do you know that they're going to start drug testing people on welfare and stuff? Florida starts next
They
month.
need to.
Florida they took it in and starting the 1st of July, they will start drug testing those who get benefits from the state. So,
I think that's a good idea because a lot of times that money is being spent on drugs. So.
It makes me mad.
Makes a lot of people mad. If ethnic roots are strong and the loss of friends who speak the native language may be a big loss to that elderly person. Because a lot of times, and Wesson, you can relate to this, and I'm sure, Lou, you can relate to it too, that when, as you get older, if you're here in this country with your family, the family begins to speak English, but that elder person still speaks their native tongue and is not able to communicate with other people. So if they live in a community that maybe had a group of them came over here together, and you begin to see those others die off and they have nobody that they can talk to, how difficult that could be for that elder person. We see that they will deny, or the children sometimes will deny them to be able to practice their ethnic practices that they may have come over with. They have a loss of their own self-being because there's nobody else there that practiced the same things that they did. And so therefore you begin to see them not feel as important, and they begin to basically wither away. We need to always think about it and respect their values and their beliefs because that is important to them. It may not be as important to their younger generation that was raised here in the United States, but it was important to them, and we need to respect that. Make sure that you assess that part of their being, their cultural background, and the importance of that cultural background, and try to help them, to maintain some part. We had a patient that was from New York that was in the nursing home here in Alabama. Well, even though, yes, she was from the United States, but they do things differently up north than what we do here in the South. And so, therefore, we tried to help her. She was Catholic. The church services that are held in the nursing home, it's either going to be Baptist or Methodist. So we had to make some adjustments for her, and provide her. We didn't have a Catholic priest to come in, to do services because she was the only Catholic in the facility. But we were able to, get tapes and, and videos of Catholic services, so that she could still maintain that part of her life, as best we could. We had one that was also from New York, so we've had two. The last one we had was her son owns the Landau company, or owns one of the companies anyway that does Landau uniforms, and we didn't always have the foods that she liked, but we had to try to make some adjustments to fit what she wanted. And she got to the point where all she would eat was tomato sandwiches.
Oh.
Now, that's not something you typically see in the North, but that was the only real Southern food that she liked was tomato sandwiches. So she got a lot of them.
Why would there be somebody from New York down here because their children were here or something?
Yes. Hey, the term ethnogeriatrics is one you might see that basically just is looking at the culturally competent care to be provided to the ethnic elders. Another term that you need to be aware of is ageism, and it's a negative attitude based on age. You know, a lot of times it does lead to discrimination in the care being given to the older adult. We tend to, as a society, stereotype the elderly and say that all elderly are incompetent. All elderly are not incompetent. But just like the term racism applied to discrimination to a race, ageism applies to discrimination to the age. Nurses greatly benefit from gaining knowledge about normal aging, physical development, and cognitive development. Because how many of you thought that all elderly were senile? Just the ones driving. All the elderly are not senile.
I ain't gonna say that.
All the elderly are not in nursing homes. They're out functioning as citizens in the community. So you have to think about that and know that just because they're a certain age does not mean that they have Alzheimer's. And that a lot of times that is assumed. Just because they're a certain age does not mean they have dementia. Those are disease processes. Do what?
My mom said I got Alzheimer's.
Sometimes I feel as if I have Alzheimer's.
My brother's granddaddy is 92, sharp as a tack, and she still stays at home, does whatever he wants.
And that's wonderful. Absolutely wonderful. Most of your older adults are physically active. They are intelligent and socially engaging. They get out, they do things. A lot of times when our patients come into the nursing home and they don't want to eat, it's because we're putting them in a room by themselves, in their room, to eat. That's when we encourage our patients to go to the dining room, to be social, because they will eat more in that social atmosphere than they will in a room by themselves, because they're talking and enjoying what they're eating, you know, while talking to others. Our extended lifespan does allow elders to enjoy their retirement. I remember my mom, when she retired from work in 1989, and she was 65 years old. Or, no, she wasn't quite 65. She was 62, I think. And she decided to go ahead and retire. She decided not to wait till she was 65. That's what it was. Because she had seen co-workers wait till they were 65. And within a few months after they retired, they were dead. So she decided she wanted to go ahead and retire at 62 so that she could enjoy. Well, look at her. She's 86 years old and still going just like everybody else.
Does she still drive?
She drives to Wadley, but that's all. We don't allow her to drive to Roanoke. And she lives out in the country. But the only reason that we allow her to drive to Wadley is because that still keeps her going. That's her. She goes to Dollar General, she goes to the bank, she goes to the beauty shop, and she goes to the truck stop. That's it. As far as she goes. To 70. By the time I get there, it'll be 80. Going back toward Lafayette, after you cross the river bridge, there's the market.
I don't know.
It's a grocery store. Grocery store, deli, and gas station.
I just, only thing I know now, I'm getting White List College. It's my first time.
We'll just keep going up 22 and you'll see it on the left. But it does, nursing care does pose the special challenges because of the diversity in the client's physical conditions, their cognitive conditions, as well as their psychosocial health. Because of all the variety of different disease processes that we have, psychological, psychosocial disease processes as well, we have to be ready to assess and take care of just about anything within that elderly population. Okay, I want to, before you take a break, I want to read you a poem. It was written by an elderly woman in the nursing home. It's called The Old Woman. What do you see, nurses? What do you see? What are you thinking when you look at me? Do you see a crabby old woman, not very wise, uncertain of habit, with faraway eyes? A person who dribbles her food and makes no reply when you say in a loud voice, I do wish you'd try. A woman who doesn't seem to notice the things that you do and forever is losing a stocking or shoe. A person may be resisting at times, lets you do as you will with my bathing and feeding and handing me my pills. Is that what you're thinking? Is that what you see? Then open your eyes, nurses, because you're not looking at me. I'll tell you who I am as I sit here so still, as I rise at your bidding, as I eat at your will. I'm a child of 10, with a mother and father, and brothers and sisters who love one another. A girl of 16, with wings on her feet, dreaming that soon now a lover she'll meet. A bride soon at 20, the heart gives a leap, remembering the vows that I promised to keep. At 25 now, I have young of my own, who need me to build a secure, happy home. A young woman of 30, my young now grows fast, bound to each other with ties that should last. At 40, the young ones are grown, and soon will be gone, but my man stays beside me, so I don't feel so alone. At 50 once more, babies play round my knee. Again we know children, my loved one and me. Dark days are upon me, my husband is dead. I look at the future, and I shudder with dread. For my young ones are all busy, rearing young of their own, and I think of the years and the love I have known. I'm an old woman now, and nature is cruel. Nature makes old age look like such a fool. The body is crumbled, grace and vigor depart. There is now a stone where I once had a heart. But inside this old carcass a young girl still dwells, and now and again my battered heart swells. I remember the joys, I remember the pain, and I'm loving and living life all over again. I think of the years, all too few and gone too fast, and I accept the stark fact that nothing can last. So open your eyes, nurses, open them and see. Look a little closer, nurses, please, see the real me. When you go into that nursing home in a couple of weeks, think about that. Don't just see what is on the outside of that individual, because you may see food or drink coming from their mouth. But look at what they were once right where you are. They were once young and vibrant and had a world of life before them. So think about that when you go in. Okay? Y'all can take a break, because we're all going to cry. So. I look at my mom, and she was 43 when I was born, and I'm almost at 43, and I think, and I just think, what could she have been thinking?
Mama's birthday she first, and my aunt You made everybody have to call their grandma when they got outside one day.
Oh, really?
My grandma's my best friend. I don't know what I'd do without her.
All right. Okay, physical development in the older adult. Your physical development is not, the changes there is not associated with disease process. But we're going to look at what is normal aging process. Some of the changes are visible to the eye, but some of them are not. Like your cognitive changes are not visible. You cannot see those changes, but you see short-term memory loss. See, a lot of times as we grow older with cognitive, the brain actually begins to atrophy a little bit, which is a normal aging process. And it's dependent upon how severe that atrophy is as to whether or not it's a disease process or just normal aging. But you will see some short-term memory loss because of it. If you look in your book, let's see what page. How far are you book?
Okay, it's on page 586 in the book.
So some of the things I want to point out, and I forgot to bring my book down. With your skin, you will see the brown age spots that will occur. Sometimes they will be referred to as liver spots. You know, the little brown spots you particularly get on the hands and all. The skin, as we mentioned earlier, gets dry. You don't have a lot of moisture on it. That's why with the elderly, you want to make sure you're putting lotions that will moisturize it, that you're using the soaps that will moisturize the skin, rather than like Dial, for instance, which is a great soap. It doesn't have any moisturizer in it. So Dove is the better choice, because Dove does have moisturizer, and it actually has some bars as well as some body washes that are out that have extra moisturizing capabilities to it. We typically see that the extremities will get cooler to the touch because circulation decreases as we get older. So we'll see that. Your little elderly folks stay cold all the time. Even though it may be 90-degree weather outside, you're going to have some of them wearing sweaters. And it's because they lose their subcutaneous fat. So that's, something that we have to make adjustments for. Put a sweater on them, give them a blanket, to help them to be more comfortable. The hair begins to thin, the graying increases. It began to thin and it began to gray in the middle-aged adult. That's when it begins. But as we get older into the older adult, you will see that it continually, I don't want to say gets worse, but it continues to change. With the head and neck, you'll see that you'll have loss of hair on the face. You'll have, with men particularly, their eyebrows become more bushy looking. So you'll see that occur. That you are easier to bruise with the integument as we get older. We're a lot easier to bruise during that period of time. With the eyes, the visual acuity decreases. You get decreased accommodation, so it won't be uncommon when you do accommodation on a patient that their eyes won't constrict as quickly to that closer point as yours or mine would, because it does change over time.
So when you document that,
You could say sluggish reaction to accommodation, because normally it should be brisk, so sluggish would be a term you could use with an older adult. Okay. The taste buds tend to change. Your smell tends to change. My mom lost a few years back. She lost probably 20 pounds because not only was her taste buds changing to getting older, but that was at the same time we identified the lung problem that she has, and it produces a lot of mucus, which gives a foul odor to the breath, as well as causes more changes with taste. So therefore she began to lose weight. We thought she had cancer. She coughed all the time, coughed up all this copious amounts of secretions, and so we thought she possibly had lung cancer. But it ended up she didn't. It is a chronic lung problem, but it caused the different changes that added to what normal processes was already doing. The normal aging was already occurring, and that just added to it. So, with the lungs, you will have decreased expansion because you have decreased elasticity as we get older. So you will see that they will actually increase their respiratory rate as they get older because the lung expansion is decreasing, so you're not able to get as much oxygenated air into the alveoli. And so they will tend to have lots of times a little bit lower than normal O2 sats. Where we want O2 sat to be 95 to 100, they may be low 90s. Okay? With the blood pressure, with the heart and cardiovascular system, we typically see as we get older, the blood pressure will elevate just slightly as far as the systolic pressure. Your diastolic will typically be, should be normal, but a lot of times with the elderly we'll see the top number will increase. Your pedal pulses begin to get weaker and the lower extremities get cooler because of the decrease in circulation. You will also have orthostatic hypotension as a normal aging process that might occur. So if they're already on blood pressure medicines, then you have to pay real close attention to their blood pressure when they go to get up. Make sure they sit and dangle rather than just all of a sudden get up. With the breast, they have decreased breast tissue, and a lot of times what you see there is they will become pendulous, where when they bend over, it swings back, the breasts swing back and forth just like a pendulum on a clock, would do, and that's due to lack of breast tissue. Gastrointestinal system, we decrease our salivary secretions. The overall gastrointestinal system slows down and doesn't work as fast and efficient as it once did, so you get more problems with constipation. Your little elderly folks become very obsessed with their bowels, but it's because everything slows down that they're getting constipated. With the reproductive system, You've got a decrease in estrogen and a decrease in testosterone in men, so therefore you have changes that would occur due to a decrease in hormones. They have decreased, with females, you have an increase in vaginal dryness because of the decreased secretions. And with males, you have decreased sperm counts, and you have erections that are less firm and slower to develop, and you also see decrease in testicular size. With the urinary system, the kidneys don't function as well, so you have loss of protein from the kidneys. You will have nocturia that will occur. You also will see that the kidneys are not filtering as well as they should, or as well as they once did, because the filtration has slowed. So you then have to worry about medications that they're taking, and you have to start thinking, well, if they're taking this medication, I may have to, or the doctor may have to adjust the dosage because it's going to stay in their body longer. Because that whole process of breaking down the med slows, as well as the excretion of the med is going to slow. So you may have to do some reduction in dosage in order to keep them from becoming toxic with those medications.
I didn't know that on the testosterone, I thought it was just like women's hormones. They have to take medication because they get unbalanced and stuff.
Mm-hmm.
Well, a man in testosterone, that's pretty much the way the doctor described it to us was your energy, you get up and go throughout the day.
Gone.
When it's low, a man doesn't have the energy to even go to work hardly. It just takes everything out of him.
Mm-hmm.
I didn't know that had a relation with the testosterone.
Mm-hmm. It does. And it also with the behavior with low testosterone levels as well. They will be much more irritable with low testosterone. They also develop insomnia with low testosterone. A lot of the males, we've taken care of some in the nursing home that we had to give testosterone injections to because their behavior just gets so bad, their outburst, that they could hurt someone.
Really?
Yeah.
See, I give my husband a shot every month because his energy level just went to zero. I mean, it was just everything he did, he had to go to work, and we didn't know what it was. And we had a pre-workup done, and it was testosterone level was nothing. And it really helps him throughout the day.
Yeah, it will. It'll make a big difference in the way they feel, their life in general. Yeah. With the musculoskeletal system, we've already mentioned you have decrease in muscle mass, decrease in strength, and then neurologically, the reflexes decrease tremendously. My mom just went back and got her driver's license renewed, and I'm like, Mom, do you really want to do that? Your reflexes have decreased. I worry so much that she's going to pull out in front of someone, and not be able to stop, or whatever. And I've tried to go over these normal aging changes with. She doesn't always want to listen to me. No. You will also see that they'll have insomnia a lot of times, shorter sleep periods, because all their bodily functions have slowed down, so they don't require as much sleep as what you and I would actually require, because everything's slowed, so the body doesn't have to work as hard, and so it therefore doesn't need as much rest. And they also have a decreased ability to respond to multiple stimuli at one time.
Oh, I heard that when you get older, trying to multitask is not good for you.
It doesn't work as well. Multitasking doesn't work as well. But you have that page here in the book. You also should have one. Yeah, middle-aged adult was on page 583. Most everything is still fairly well intact with middle-aged adult, but it says we get older and older, everything begins to slow down. Notice here, researchers generally believe that there is minimal change in intellectual capacity of the healthy aging adult, but the ability to learn and memory is affected by the aging process. It's not that they can't learn, it just takes them longer. So, tasks that, like for instance, if they're a diabetic and they need to go on insulin shots, it's going to take them longer to learn how to give themselves insulin than it would someone at a younger age. So the old saying, you can't teach an old dog new tricks, is totally inaccurate. You can teach them, it just takes longer. But how old is he? Mm-hmm. It's not the case in his situation. I would bet that it's not that he don't know how to do it or can't do it, or he is in denial of the whole aspect of being a diabetic. And so he's got to work on that before but he'll eventually get it. He'll eventually do it. Yeah. Learning with older adults is facilitated with visuals, auditory, and sensory cues. A lot of times, you just have to cue them to do something. As you go to the nursing home, you'll see that some of our folks can feed themselves. You just have to cue them to do so. So you'll eat, Mrs. So-and-so. Could you get your spoon and put it in your mouth? They need those cues to be able to do. Okay? Always when you're doing assessments or teaching with your older adults, encourage them to wear their glasses and to wear their hearing aids if that's a requirement for them, so that they do learn what needs to be learned and they didn't miss it because they didn't have the hearing aid in. We also need to provide glare-free lighting, because as we get older, that glare, it makes it much harder to be able to see what is being done. Provide quiet, non-distracting environment. Turn the TV off. Don't have the TV on when you're trying to teach the patient or when you're trying to assess the patient, because that's going to distract them. One of the requirements in the nursing homes is that the TV has to be cut off during mealtime. Now if they're in their own private room, that's a different story. But in the unit dining room, it has to be cut off during the mealtime so that they can concentrate more on eating and not be distracted by the TV. Set short-term goals with the elderly. You can't expect them to learn large amounts of information in a long day. Okay, they couldn't come in and sit in a class all day long. Short term, you teach them short periods of information and then get them to return, demonstrate it to you so that you know that they learned it. Pace it as well so that you keep them interested. Encourage the verbal participation and reinforce their learning in a positive way. A lot of times they'll be negative about themselves, but you need to be positive. No, you did good. See what you did? You were able to give that shot, or you were able to draw it up. We'll work on giving it tomorrow. Yeah, but be encouraging to them. Most older people who want and need to learn new skills and information can. It just needs to be presented more slowly and over a longer period of time. Continuing mental activity is considered essential to keeping older adults alert. The little elderly folks that you see doing the crossword puzzles and word searches and reading, that's keeping their mind active. That's what my mom does all day long. She either watches TV or she's got her a word search book that she's doing word searches in, or she's reading her Harlequin romance. It keeps her mind active, and that's the best way. You want to keep their mind active, keep them engaged, because they will stay much more alert and oriented a lot longer than if they just sit and do nothing. With the psychosocial development in the older adult, their central task is integrity versus despair. You see here that a lot of things that they can do that help them to adapt is they can volunteer. That's a good thing. If you go to the hospital at Opelika, you'll see all the little elderly folks in the community there volunteering. They're taking people to the different places in the hospital and doing different things, which is great. Their retirement does represent most 30 years of life, most of them, if not more. Depends upon what age they went to work in. So it is difficult for them, some of them. But if they are active, if they get out and volunteer, then that's going to help them to adjust. It's that little elderly person that's following around behind their wife all throughout the day that's not adjusting well. That just doesn't have anything else to do except follow around behind somebody. Or that sits there in front of the TV all day long and sleeps. They've not adjusted well. They need to be active, need to be doing something. Integrity, if they have accomplished integrity, then they're looking back at their life and feeling positive about it. They're looking back at their accomplishments. They're not looking back at their failures and dwelling on those failures. They're looking back at their accomplishments and say, I did it. I made a life for my family, and I did it. And I'm proud of what I did. Okay? If they're not proud of the things they did, they're looking back at their failures, and they are in despair. The person that's in integrity has accepted that death is imminent, because they're typically, you're 65 and older. Death is coming sooner or later, and they're accepting of that. If they are not accepting of that, then they're in despair. When they're not looking at their accomplishments and thinking positively and accepting death, then they're in despair. If they're looking at their failures and all the failures that they had, and they don't have any acceptance of death or spiritual acceptance or otherwise, then they are in despair. The elderly have to make a lot of adjustments in their life. They have deaths of family and friends and spouses that can be very difficult for them, especially in a situation where the spouse is the one that always took care of everything, and then they're faced with having to do it themselves. That can be very difficult for them. They're losing friends. You know, I look at my mom and think about all the people that she graduated from high school with, that through the years I met. They're all gone, but maybe two. I think it's her and one more that's left. So she's watched her friends. So that can be very difficult at times. We have to look at them being alone. You have to differentiate between being alone and loneliness. My mother lives alone. She is not lonely. Okay? She's still very active, and she has grandkids, to come in and be a part of her life. So don't get those two terms confused. Living alone is one thing, but being lonely is something totally different. That being lonely is that feeling of emptiness, that nobody cares, nobody's there. I may not see my mom every day because of various things that I'm involved in, but she's not lonely. Housing and environment, there is always a change in living arrangement, or can be a change, and it can have a major impact on that elderly person, both physically as well as mentally, with the changes that can occur. So a lot of times they're faced with having to lose their home because they can't afford to keep their home up. They can't afford to have someone cut their grass on a daily or on a weekly basis. They can't afford all the things that go into maintaining that home because of the limited income that they're on. So that can be very difficult. A lot of times you'll see patients that have just moved out of their home and went into a retirement community because of not, when you live in a retirement community, someone else takes care of all the maintenance of the home. So that can be something you might see. Health promotion, remaining reasonably healthy and fit, depends on the person's lifestyle and choices. Many of them, and those that you see out going camping and going on vacations, they're all physically fit because they want to be able to maintain their health and to get out and go and do things. Some of them sit at home and don't do anything, so you have to encourage them, and you want to highly encourage them to maintain a healthy lifestyle, being active and eating the right foods. Many of them are in good health. However, if they do have a chronic illness, then they tend to age much faster. At the same time, we do see a lot of chronic illnesses begin to occur as they get older. My mom never had any problems when she was younger. It wasn't until she reached about the age of 75 that she began to have problems. She ended up in the hospital a few years ago with a heart problem. She's now on medicine for heart and lung problems. She never took medications as a younger adult. So your chronic things do tend to increase with age. Coronary artery disease is the leading cause of death for 65 or older. We also see that hypertension contributes to both strokes and heart attacks. We do see that the black population or African American population is at a greater risk than white, and men are at a greater risk than women. So African American males are at a greater risk than women for developing hypertension. Cancers are the second leading cause of death. And then we also see a lot of sensory impairments, and some of those sensory impairments may also go along with a chronic illness such as diabetes. It may go along with a chronic neurological problem. Could go along with your coronary artery disease. If you have peripheral vascular disease, the sensory changes occur there also. We also see them having dental problems, loss of teeth, a lot of issues with the mouth. Older adult women are often discriminated against for being elderly and being female. We do see older adult males being discriminated against as well, but your females are going to be most often discriminated against. We also see that cognitively impaired older adults tend to be discriminated against as well as our rural older adults, because they don't have as much access to health care, and they don't have they have a higher poverty rate, and they tend to be more geographically isolated, so they tend to be have some discrimination there as well. Older adults that are homeless, we also see some of those occurring. We don't see as many homeless older adults, though, as we do middle-aged adults, I don't think. Your frail elderly, they're the most vulnerable. They typically have a lot of chronic illnesses, and we begin to see that they have a higher risk for malnutrition because they don't have the means to support themselves, and they don't have food that they can prepare for themselves. A lot of times they don't have the energy to prepare it a lot of times. Nursing ethics for care of the elderly. Always remember to treat each individual with dignity and respect, regardless of what their age or status is. Each person is a valued person, and they are it's worthwhile getting to know them. Have the right for adequate access to the best health care. Just because they're elderly doesn't mean they shouldn't go to the doctor. They have the right to the very best. We have to demonstrate the good of the client, or our behaviors need to demonstrate the good of the client before the good of the system. So take care of that individual just as if they were a young adult, in other words. Don't skimp on their care just because they are elderly. They have the right to the best of care, and it's our responsibility to make sure that we put them first rather than the system. And with the system referring to things like the insurances and the Medicare and Medicaid, we need to put the patient first and not worry about what the cost is going to be or what the insurance is going to pay. Take care of the patient. Each client has the right to decline invasive treatment or life-extending treatment. That's up to them. If they're cognitively able to make the decision, that is their decision. And we should respect them as decision makers about their own care and let them stay involved and independent in their care, have some autonomy of their own care. That's one of the things we stress in the nursing home. When you walk into that nursing home, that is their home. They have the right to refuse what you do to them or for them. So keep that in mind. As healthcare providers, we must avoid paternalism, treating that adult or that older adult as if they're a child. We don't need to do that. They are adults. Don't call them honey. Don't call them granny. Don't call them sweetie. That is improper communication. Okay, you need to make sure that you are addressing them as Mr. or Ms. unless they tell you otherwise. Now, we have one little lady up on Unit 2. She may have passed away. I can't remember. Her name We called her Momo. It was care planned. Put in her care plan to call her Momo, because that was the only way she would respond to you. Okay? But unless they tell you to call them something different, it is Mr. Jones or Ms. Jones or Miss Smith or whoever it is that you're talking to. You call them by their name, Mr. or Ms., until they tell you otherwise. Okay? And there are some of them that will tell you, I don't want to be called Ms. Jones. I want to be called Joe or Lucy, whatever the case may be. And that's fine if they tell you that. But they have to be the ones to tell you. Teaching the older adult, you need to be aware that you need to make sure that you have set aside plenty of time, because they will need time, an increasing amount of time to learn. New learning must relate to their actual experience. So whatever you're trying to teach them, you've got to help to relate it to something that they can understand. Anxiety and distractions will decrease learning, so if they are anxious that day, that's not going to be a good time to teach them. Again, turning the TVs off, turning the radios off, just making it one-on-one, you're face-to-face with them so that they can learn what you need to teach them. A lot of times they don't want to learn because they're afraid to take a risk. That's one thing that we see in our nursing home patients. They don't always want to try something new because that's a risk. And so we have to be very cautious with that and help them to make those adjustments. The we? Yes, they do that in activity.
Okay, well, the nurse home I worked at, they didn't like the weed.
Really?
Yeah. Because they relate that more to like kids.
I don't know I honestly don't know what their thoughts on it are. I've not seen them doing it, but I know that is an activity that they do.
I think it would be good to bowling and stuff.
Mm-hmm.
My mother-in-law loves the weed. We
Yeah.
don't even in a nursing home.
Now, they always loved bowling, as far as they would set up the pins and they would actually bowl. But they are using the Wii for bowling now.
Right.
And best I understood, they like it, but I've not actually seen them.
We had it for therapy.
Mm-hmm.
Okay, my therapy company about us one, and we could not get them to participate and do it. I mean, we enjoyed it more than they did,
Mm-hmm.
but we just understand.
It will vary, but from what they had said, our folks like it. So you do have to take into consideration their sensory changes. That was the last statement on the other slide, before teaching, so that you provide them with the materials that they need, that they can read if they want to read it, or that they can see. You have to take all those sensory changes into your thought process when planning. Economic factors that can affect the elderly. We mentioned housing earlier. A lot of times they do end up moving out of their home just simply because of not being able to maintain. Shopping can be a factor. Shopping versus buying medicine. Do I have the money to get my food today, or do I need to buy my medicine today? And that has to be considered. We also have to consider the fact of transportation with shopping, because they may not be able to drive, or the family may not want them to drive, and so you've got to take that into consideration as far as getting their groceries or whatever their needed supplies may be. Increased drug and health care costs also have to be taken into consideration, because remember, they're on limited income. Also, what we see with drugs, another term that you need to be aware of is polypharmacy. I think Ms. Capeless talked to you a little bit about polypharmacy. It particularly happens with our elderly. They go to several different doctors and they give them medications. Some of them will give them medications for the same problem, not realizing that they're already on something for that problem, unless they take their medications to the doctor with them, which is what they need to be encouraged to do. They need to take all their medicines to every doctor's visit. I remember taking care of a little elderly guy at Lanier several years ago, and he had his medications with him, and he had 2 of the same exact medication, just in, one was the brand name form, one was the generic form. Exact same medication from 2 different doctors. So you have to make sure, and even there are times when it'll be the same doctor. But if you don't specifically tell that patient, do not take this one anymore, then they will continue to take it just like it was ordered. Okay, so you've got to be very clear to them. You know, let me have the bottle, I'll dispose of it. You know, or something just to keep them from double dosing themselves. Also, a lack of insurance can affect the elderly economically. We had a guy not too long ago that when he turned 65, he refused to take Medicare. He wasn't paying for that. So it was, he had no insurance. He was private pay because he didn't want the government having any control over his health care. Some of them are. So you may see that. You may see a lack of insurance, or you may see only Medicare or only Medicaid, rather than them having a supplement that will pick up and pay where Medicare or Medicaid leaves off, particularly Medicare. The elderly use more drugs than any other age group. Note here they average more than 15 prescriptions and renewals a year. More than 15.
That's what we have to look for.
But also remember that each drug is going to vary from what it normally says with how fast it should just absorb, how fast it should be distributed within the body. As we get older, it's not going to go by what it says on the bottle as to how fast it will do it, because everything slows down. And so we have to realize that and make sure that we as nurses have to alert the doctors to that a lot of times because of the age of that individual. Just stretching. Your elderly also have the highest user rate of over-the-counter drugs. So you have to pay attention to what over-the-counter drugs they're on to see if there's any interactions with the prescription medications that they're on. And then we also, once again, have to realize that liver's not metabolizing as fast, and the kidneys aren't excreting it as fast. So we have problems that will develop from that. Home health care can be a cost-effective alternative for a patient to be able to stay at home rather than be admitted into the nursing home, and as we talked about earlier, losing their home, their money, everything. They do have to be homebound in order to qualify for home health. Hospice, they don't have to be homebound, because with hospice encourages them to maintain their activity as much as possible to be able to enjoy the remaining part of their life. Hospice focuses in on the quality of life rather than the quantity. So, but with home health, they do have to be homebound, and it depends upon what level of care they need as to whether or not home health can be a part of their care process. In conclusion, we do have opportunities to care for older adults in all types of settings, whether it's in the hospitals, the nursing homes, the home setting, doctor's offices. We have great opportunities to care for elder adults. We need to make sure that as nurses we're looking toward that elder person with a positive outlook rather than having that ageism be a part of us in the way we look at that older adult. Most of them do continue to function very well despite the effects that aging has on them. If it's normal aging process, they're typically going to do pretty well. It's when you have those disease processes that occur, those chronic illnesses that occur, that really makes a big difference in their life. We need to teach older adults about things that are modifiable. It's never too late for them to change their behaviors, like with their nutrition, for instance. If they've got high cholesterol levels or high triglyceride levels, then we need to teach them about modifying their diet. It's not too late for them to improve their health and hopefully improve their quality of life. And note this last statement here. Working with the elderly is a great opportunity to teach, but it is also a great opportunity to learn, because you can learn so much from that elder person. They've lived a long life, and a lot of them have lived very long, good lives. And so they have a lot that they can share with you about what you're doing, about your family. They can share things with you that they did for theirs that may help you somewhere along the way. So when you go into the nursing home in a couple of weeks, use that opportunity not only for you to learn about nursing care, but also to learn some possibly very good life lessons from those elderly patients, because some of them will be pretty good. Any questions? I actually finished a lecture.
I was thinking it. I looked and I said, "What more pages?"
I'm excited. We're doing the first part of the last part of communication and documentation is what we're doing, and hopefully be able to start some nursing process. That is what we had said, right?